Hello, everyone. Thanks for joining us today to speak about myelofibrosis, a new treatment option. And the discussion focuses on a drug called Rubik, also known as fedratinib, which is newly approved and is indicated for the treatment of adult patients with intermediate 2 or high-risk primary or secondary polycythemia vera or post-essential thrombocythemia myelofibrosis. This is a Celgene promotional program. I'm speaking on behalf of Celgene. I've been paid to conduct this presentation. The information is consistent with FDA guidelines, and the program is not an accredited CME program. If you have questions along the way, please feel free to submit those, and we'll address them at the end of the program. So we'll begin with an overview of myelofibrosis. It is a cancer of the blood and bone marrow. It is fairly rare. The median age of diagnosis is 65, and the estimated prevalence of myelofibrosis in the U.S. is 18,000 cases. It does have a complicated symptom profile. The symptoms may vary, but they frequently involve constitutional symptoms such as night sweats, fevers, weight loss, low blood counts, and an enlarged spleen. Our primary scoring system is called the DIPS or DIPS Plus. There is now a new model called the MIPS 70 Plus, which takes mutational abnormalities into account. The components of the DIPS Plus scoring system is age, hemoglobin less than 10, peripheral blast, constitutional symptoms, white count greater than 25,000, red cell transfusion dependence, and then platelet count less than 100,000, and abnormal karyotype. And so we basically add up all of these different values and place patients into one of these predictive groups. And you can see that the survival could vary anywhere from 15.4 years to 1.3 years. I'll also mention, just for the purposes of this presentation, that whenever you develop an intervention, you do want to know how people do after they fail that intervention. And we do know that for patients who progress on ruxolitinib or have discontinued it for other reasons, the survival is 14 months. So progressing on ruxolitinib, stopping ruxolitinib does predict for an inferior overall survival. One of the more following signs and symptoms may trigger evaluation, and that would include an increase in spleen size, a change in symptom status, or worsening blood counts. You should monitor for return worsening or new onset of signs and symptoms. Now, Rubik is indicated for adult patients with intermediate 2 or high-risk primary or secondary myelofibrosis. There is a black box labeled warning about Wernickesencephalopathy. And so we'll go through this in detail now, and this same slide will appear several times during the presentation. If you do have a patient with a thiamine deficiency, that needs to be repleted before you treat the patient. Fedratinib does have a molecular structure similar to thiamine, and there were concerns that taking Rubik or fedratinib may interfere with absorption of thiamine. And there are patients that have been described to have a neurologic deficit that does appear to behave similarly to Wernickesencephalopathy. And so serious and fatal encephalopathy has occurred in Rubik-treated patients. Serious cases were reported in 1.3% of patients treated with fedratinib, and 0.16% of cases were fatal, so that's 1 out of 608. A couple of points about this data. This is patients treated overall with fedratinib, so it's not specifically myelofibrosis patients. And so there were several phase 1 studies looking at different types of disease processes. So there's a wide variety of malignancies that were included in this data set. So it's not just taken from the patients who received it for myelofibrosis. Wernickesencephalopathy is a neurologic emergency that results from thiamine vitamin B1 deficiency. The signs and symptoms include ataxia, mental status changes, and ophthalmoplegia. If you do have a patient on Rubik or fedratinib that develops mental status changes, the fedratinib should be discontinued immediately, and thiamine levels should be checked and replenished appropriately. Rubik is an inhibitor of JAK-STAT signaling pathway. It's JAK2 selective, and it has a higher inhibitory activity for JAK2 than other types of JAK-STAT pathway activators, such as JAK1, JAK3, and type 2. So there are several different JAK inhibitors, JAK-STAT pathway blockers that are either approved or in clinical development, and they do have differences in regards to their Michaelis binding coefficient or these different receptor subtypes. So there are certain differences between these different JAK-STAT pathway inhibitors. It does have an effective half-life of 41 hours, a terminal half-life of 114 hours, so it's a once-daily medication. You don't need to take it twice a day like other types of JAK inhibitors. It is started at the full dose if the patients have a platelet count of greater than or equal to 50,000. You should reduce the dose to 200 milligrams in patients who are on strong CYP3A4 inhibitors, and you should reduce the dose if they have severe renal impairment. So the recommended starting dose is 400, but if they're on a strong CYP3A4 inhibitor or they have renal impairment, then you want to start at a lower dose. You should avoid the use of Rubik with strong and moderate CYP3A4 inducers, and then avoid use of Rubik with dual CYP3A4 and CYP2C19 inhibitors, and avoid use of Rubik in patients with severe hepatic impairment. Fedratinib may be taken with or without food. Administration with a high-fat meal does reduce the incidence of nausea and vomiting. Patients who were on Jakafi or ruxolitinib before the initiation of fedratinib must taper and discontinue according to ruxolitinib prescribing information. So you wouldn't want to give patients concurrently both ruxolitinib and fedratinib. There is some interaction primarily with strong CYP3A4 inhibitors that increases fedratinib exposures. So this would principally be azole therapy and HIV-related medications. Pregnancy and lactation, you should consider the benefits and risks of fedratinib for the mother and possible risks of the fetus when prescribing the medication. And due to potential serious adverse reactions in breastfed child, advise patients not to breastfeed while taking the fedratinib and for at least 1 month after the last dose. You should reduce the Rubik when administered to patients with severe renal impairment. No modification is recommended for mild to moderate impairment. And avoid use of fedratinib or Rubik in patients with severe hepatic impairment. So the data to support the use of this drug comes from a randomized, double-blind, placebo-controlled trial called JAKARTA. In order to be eligible, patients had to have intermediate 2 or high-risk myelofibrosis, post-PV or post-ET myelofibrosis with splenomegaly. They were randomized in a 1-to-1 fashion to either placebo or to a 400 milligram dose of Rubik or to a 500 milligram dose of Rubik. And they took the medication daily for at least 6 cycles. A cycle was approximately 28 days. Patients continued to receive their Rubik as long as they were benefiting. If they had progressive disease or relapse or unacceptable toxicity, the drug was stopped. The primary endpoint was 35% reduction from baseline in spleen volume at the end of cycle 6, as measured by MRI or CT with a scan 4 weeks later. Secondary endpoints included a greater than or equal to 50% reduction in total symptom score. So the total symptom score is well established in myelofibrosis and a validated model for following symptoms. Why 35%? Because that's basically what was decided at the beginning of when these types of JAK inhibitor trials were first being developed as being clinically significant. So that's why the 35% reduction was chosen as the endpoint of the studies. The median age was 65, male 59%, older than 65 years of age 47%. Most of the patients had primary myelofibrosis, and then you had to have intermediate 2 or high risk in order to meet eligibility criteria for the study. So that's the breakdown there. And then you see the median hemoglobin, platelet counts. The median palpable spleen length was 15 centimeters, and the median spleen volume was 2.5 liters. In regards to the primary endpoint, 37% of patients in the Rubik arm, 400 milligram dose, met the primary endpoint, 1% in the placebo arm. Both the 500 milligram dose and the 400 milligram dose had similar results in regards to the primary endpoint. but there was more gastrointestinal toxicity observed with 500 milligram dose, which is why the 400 milligram dose was chosen for the FDA-approved dosing. On the other side, you see the waterfall plots. And I think an important point about these waterfall plots is that although only 37% of patients met the 35% spleen volume reduction cutoff, a greater percentage, as you can see, did have spleen volume reduction. And only about 2 to 3 patients in the study actually had an increase in spleen size, and that is in marked contrast to the placebo-controlled arm. I'm still here. I just wanted to close the door to eliminate some background noise. And now we're moving on to the secondary endpoint, which was the symptom reduction. And that was a percentage of patients with a greater than or equal to 50% reduction in total symptom scores from baseline. You can see that in the active treatment arm, it was 40%. Similar results were seen in the 500 milligram arm, but with more toxicity, which is why the 400 milligram arm was chosen. You are going to have more of a placebo effect with symptoms, as you would expect, and that placebo effect was about 9%. And then when you look at the waterfall plots, there were more patients in the Rubik arm that also had symptom reduction, but you can see that some of the patients in the Rubik arm did have worsening symptoms. And then you see the placebo waterfall plot, which is about half and half, which is basically what you would expect for the placebo arm. So on the basis of this, the NCCN Guidelines has as a Category 2B recommendation that fedratinib be considered for patients with intermediate to or high-risk myelofibrosis, platelet count greater than 50,000, who are transplant ineligible. So they're not eligible for allogeneic transplant. Now, what about ruxolitinib failures? And this is now moving on to a different study that's called JAKARTA 2. It was not a randomized study. It was a phase 2 trial in which all patients received the active intervention. And that intervention was fedratinib. So it was a single-arm, open-label phase 2 study in 97 patients with primary or secondary myelofibrosis who were resistant or intolerant to ruxolitinib. The primary endpoint was a greater than or equal to 35% spleen volume reduction at the end of cycle 6, as measured by MRI or CT scan. The median exposure to ruxolitinib prior to study enrollment was 10.7 months. The median exposure to Rubik during the enrollment was 24 weeks. I should have mentioned that both JAKARTA 2 and JAKARTA 1 were being conducted during a period of time in which the FDA put a hold on the study drug. JAKARTA 2 didn't complete fully enrollment, but JAKARTA 1 did. But it was still in follow-up. JAKARTA 1 was when the FDA put a full clinical hold on both of these trials. And the reason why is because of the Wernickesencephalopathy, the concern about that. So just coming back to this slide, the methodology for spleen and symptom assessment was a post hoc analysis of spleen volume in the intent to treat population and total symptom score. Only patients who were confirmed responders at the end of cycle 6 were included. Patients missing spleen volume assessments at the end of cycle 6 were considered non-responders. So basically this is their way of dealing with the study being shut down during the conduct of the study by the FDA. The spleen volume response intent to treat was 30.9%, and the symptom response was 26.7%. So there's no control arm here, but this would be considered good data compared to historical controls on patients who have previously failed or were intolerant to ruxolitinib. In regards to side effects, from the JAKARTA 2 trial, the principal side effects of fedratinib were hematopoietic and gastrointestinal. So we'll begin with the hematopoietic side effects. You can see that grade 3 anemia happened in about half of the patients. About 17% had grade 3 thrombocytopenia, and about 5% had grade 3 neutropenia. And then continuing on, this is the gastrointestinal side effects, diarrhea, nausea, vomiting that you can see listed. And just to emphasize again, the principal toxicities of the drug were hematopoietic and gastrointestinal. There is also some pancreatitis that can occur, and so grade 3 lipase increased 7.2%, and grade 3 amylase increased 3.1%. So it is recommended that you do follow amylase and lipase periodically in patients who are undergoing treatment with fedratinib, and that you also follow their thiamine levels as well. And of course you want to follow their platelet count, gastrointestinal side effects, and liver function test. So off the basis of JAKARTA-2, the NCCN Guidelines does recommend that fedratinib be considered in patients who have previously been treated with ruxolitinib with no response or loss of response, whose platelet count is greater than 50,000, who are transplant ineligible. The most common adverse reactions were gastrointestinal and cytopenias. So you see diarrhea, nausea, anemia, vomiting mentioned here. Dose interruptions due to an adverse reaction during the randomized treatment period, so this will be from JAKARTA-1, occurred in 21% of patients on the fedratinib arm. Adverse reactions that required dose interruption in greater than 3% of patients included diarrhea and nausea. There were also dose reductions due to adverse reactions occurring in 19% of the patients, and dose reductions that occurred in greater than 2% of patients included anemia, diarrhea, vomiting, and thrombocytopenia. This is moving to common adverse reactions with Rubik, looking at gastrointestinal side effects. I think that there is a little bit of an issue with how this is broadcasting, at least on my screen, but the first boxes here are all grades and grade greater than or equal to 3 adverse reactions in the Rubik arm. And then the second 2 boxes that are just white here is the placebo arm. So just to point that out, it's coming up as a blank box here. I think it's just something that has to do with the way the screen is being cast. But this is from the randomized JAKARTA trial. So we have a placebo control. So you're basically comparing the gastrointestinal toxicity in the Rubik arm versus the gastrointestinal toxicity in the placebo arm. And as I said, the patients who receive fedratinib do have more gastrointestinal toxicity. There's also more cytopenias. You can see that 30% of patients in the Rubik arm had greater than or equal to 3 anemia, whereas only 7% of the placebo arm had that. So again, just emphasizing that the major toxicities, gastrointestinal and cytopenias, anemia specifically. Serious adverse reactions that occurred in greater than or equal to 2% of patients included cardiac failure, anemia. Fatal adverse reactions of cardiogenic shock occurred in 1% of patients receiving fedratinib. Now we're looking at adverse reactions again, including liver function abnormalities, ALT increased, and again just pointing out that the white box here is supposed to have placebo in it. And so you're comparing the Rubik arm into the placebo arm, and you can see that greater than or equal to 3 was practically non-existent for both in regards to these other adverse reactions. There is a difference in regards to onset of cytopenias versus gastrointestinal toxicity. So that's important to know. But the GI side effects are almost immediate. So the median time to onset was 1 day, with 75% of cases occurring within 2 weeks. Now that is in sharp contrast to the other major adverse reactions, which are cytopenias, which take longer to develop. There's also a slide that you'll see in here that goes through how the GI side effects transpire over time. And the important point is that you should try to get people through the immediate GI side effects because it does appear to improve as patients are exposed to the medication. And how do you help get people through it? Well, you prescribe an antiemetic agent, and you also prescribe an antidiarrheal agent. so Imodium basically, and some type of anti-nausea medication. And so they can have that, and if they do develop significant nausea, if they do develop significant diarrhea, they can take these medications. And then also the advice that if they take the pill with a high-fat meal, it may reduce the nausea and vomiting. So this is the slide I was mentioning about the gastrointestinal toxicity. So you can see that it's worse during cycle 1, all of them, diarrhea, nausea, vomiting. And if patients do get through that, the gastrointestinal toxicities does decrease over time. So these are the treatment emergent adverse reactions of diarrhea, nausea, and vomiting by cycle up to 6 cycles. I do think it's important to interpret these numbers with a little bit of caution, because what happens in general is that people with the worst gastrointestinal side effects may discontinue the medication. Now that discontinuation rate we already went through, and it is fairly low, but that would be a criticism that you could raise about these comparative analysis over time between cycle 2 and cycle 6. So some of these would have dropped out. But the other argument is that patients get better in taking the medication. So they learn, that it's better with a high-fat meal. They also plan during a time of day where they can more tolerate the side effects. Obviously, if you're still working, probably not the best thing to take it first thing in the morning so that you're having your diarrhea episodes while at work. So patients learn to work around how to best take this medication with their schedule. Here are the hematologic adverse reactions. We can see the placebo group in this graph, but this is comparison of fedratinib to placebo, and there is a higher rate of hematologic adverse reactions with fedratinib compared to the placebo arm, as we reviewed multiple times. This is looking at the liver function abnormalities, the lipase and the amylase. You see it is a little bit higher than what's observed in the placebo arm, which is why it's important to follow that. Now, speaking about the median time to onset, I mentioned that the gastrointestinal toxicities were almost immediate, but when you look at the cytopenias, it is delayed. And the median time is about 2 months for anemia, with 75% of the cases occurring within 3 months. For the grade 3 thrombocytopenia, it's about 1 month, with 75% occurring within 4 months. For the transaminase elevation, 1 month, with 75% within 3 months. And for the amylase and lipase, it was 15 days, with 75% within 1 month of treatment. 51% of patients treated with Rubik received red blood cell transfusions, and 3.1% of patients treated with Rubik received platelet transfusions. So here we go with the warning precautions about the grade 3 anemia and thrombocytopenia. If the platelet count does fall below 50,000, then you would want to hold the medication. And of course, if patients have a baseline platelet count of less than 50,000, this drug is not indicated for them. Grade 3 anemia occurred in 34% of patients. Median time to onset was 2 months, 75% within 3 months. And then for the thrombocytopenia, we already talked about how it occurred in 12% of Rubik treated patients. Median time of onset was 1 month, 75% within 4 months. We've already reviewed the gastrointestinal toxicity, the hepatic toxicity, and the amylase and lipase toxicity that is listed here. As I mentioned, it is important to follow patients with an amylase and lipase after you begin this medication periodically to monitor for potential onset of pancreatitis. Patients may have elevated liver assay enzymes, and there are dose reductions and interruptions that should be performed if they develop this problem. For the gastrointestinal toxicity, you want to try to treat the diarrheal symptoms at first onset. If they have grade 3 or higher nausea, vomiting, diarrhea that's not responsive to supportive measures within 48 hours, then you have to hold the Rubik until it resolves to grade 1 or less, and then you restart at 100. And then with the hepatic toxicity, for grade 3 or higher, you hold until resolved to grade 1 or less to baseline, and then restart at 100 milligrams less. So if they were on 400 milligrams, you'd start at 300 milligrams. It comes in 100 milligram sizes, by the way, so they're taking 4 of these pills a day for the standard dosing. So it's a little bit easier to dose reduce if they develop these toxicities. And then with the amylase and lipase, for grade 3 or higher amylase or lipase elevations, you want to hold the Rubik until resolved to grade 1 or less, and then restart at 100 milligrams less. Dose modifications and treatment discontinuations with Rubik during the randomization period. Dose interruptions due to adverse reactions occurred in 21% of patients. The adverse reactions that required dose interruption in greater than 3% of patients who received the Rubik included diarrhea and nausea. Dose reductions due to adverse reactions occurred in 19% of patients. The most common reasons were anemia, diarrhea, vomiting, and thrombocytopenia. Permanent discontinuation occurred in 14% of patients, in greater than or equal to 2% of patients, including cardiac failure, thrombocytopenia, MI, diarrhea, and increased blood creatinine. In regards to the hematologic toxicity, if they develop grade 4 or grade 3 thrombocytopenia with active bleeding, hold the dose until resolved, restart at 100 milligrams less. Grade 4 neutropenia, interrupt the dose until resolved, restart to less than grade 2 or baseline at 100 milligrams less. Now for the transfusion dependence, it's a little bit, for red cells, it's a little bit open, and there's not strict guidelines regarding this, because you do have to take into account the entire clinical picture. And there are some patients with massive splenomegaly that actually do overall feel better on the fedratinib, despite the fact that they may need more transfusion support. So it just says consider dose reductions for patients who become transfusion dependent for red cells during treatment with the Rubik. So it's a little bit more open and to your judgment what should happen if a patient becomes red cell transfusion dependent. For the GI side effects, if they don't respond to supportive measures within 48 hours, hold until less than grade 1 or baseline, restart dose. We already reviewed these for the liver function abnormalities. And then if it's other non-hematologic toxicities, hold until less than grade 1 or baseline and restart at 100 milligrams less. All right, so the Wernickesencephalopathy. In the clinical development program, there were 608 patients who were included. Serious cases were reported in 1.3% and 1 fatality case. It's a neurologic emergency that can be fatal. It's attributable to thiamine B1 deficiency, signs and symptoms, ataxia, altered mental status, ophthalmoplegia. If you have a patient that develops any change in mental status, confusion, or memory impairment, that should raise the concern for Wernickesencephalopathy, and you should assess neurologic exam, thiamine levels, and consider imaging. So you do want to check a thiamine level prior to starting the Rubik. Do not start it if patients have thiamine deficiency. And then while they're being treated, you want to follow periodic levels of thiamine and monitor for signs and symptoms of Wernickesencephalopathy. If the patient is thiamine deficient or if encephalopathy is suspected, you have to stop the treatment and monitor until symptoms resolve or improve and thiamine levels normalize. So just going through what you should think about before starting a patient. You want to check the thiamine levels. You want to check your blood tests. And then if patients are on ruxolitinib, you have to taper that and discontinue before starting the fedratinib. If patients have a low thiamine level, you need to replete that before you start the study drug. The recommended dose is 400 milligrams daily for patients whose platelet count is greater than 50,000. Reduce to 200 milligrams if they have a concomitant strong CYP3A4 inhibitor, and reduce to 200 milligrams if they have severe renal impairment. If encephalopathy is suspected, immediately stop the medication. Fedratinib should not be continued. And then you want to initiate parenteral thiamine treatment. Monitor until symptoms resolve or improve and thiamine levels normalize. The median time to onset of GI toxicity was 1 day, 75% within 2 weeks. You treat the diarrhea with antidiarrheal medications like Imodium promptly at the first onset of symptoms. You should consider prophylactic antiemetic therapy. It may be taken with or without food, but GI symptoms appear to be less with high-fat meals. So in summary, the NCCN guidelines do include fedratinib. There is a black box warning label for Wernickesencephalopathy. The approval was based off a randomized double-blind placebo-controlled trial in 289 patients. There was a 3-arm study, 500 milligrams for fedratinib, 400 milligrams for fedratinib, and placebo control. Key inclusion criteria, intermediate to high risk, platelet count greater than 50,000. The patients who, primary endpoint was spleen volume reduction, secondary endpoint total symptom score, and then the 400 milligram dose was superior to placebo with less side effects, which is why it's the recommended starting dose. If a patient is on a strong CYP3A4 inhibitor or has severe renal impairment, the recommended starting dose is 200, otherwise is 400. The most common adverse reactions were gastrointestinal and anemia. Median onset of GI side effects 1 day, 75% within 2 weeks. Consider prophylactic antiemetic therapy and antidiarrheal medications. In regards to the primary endpoint, 37% of patients on the Rubik arm at 400 milligram dose had a spleen volume reduction of greater than or equal to 35%, compared to only 1% of patients receiving placebo. And if you look at the total symptom score, it was 40% for fedratinib versus 9% in the placebo arm. Additionally, JAKARTA 2 does show responses with total symptom score and spleen volume reduction in patients who are failure of ruxolitinib or were intolerant to ruxolitinib. Here we go again with the same slide we presented earlier with the black box warning label for Wernickesencephalopathy. We've gone through that in great detail. The additional warnings and precautions we have previously reviewed, as well as the GI toxicity, hepatic toxicity, and the amylase and lipase elevation. Co-administration of the Rubik with strong CYP3A4 inhibitors does increase exposure, so you need to be cautious about that. And it should not be given with the strong CYP4 inhibitors unless you reduce the dose down to 200 milligrams. We talked about the pregnancy and lactation. You should consider the benefits and risks of the Rubik, the possible risk to the fetus due to the potential for serious adverse reactions in breastfed child. Advise patients not to breastfeed during treatment with Rubik and for at least 1 month after the last dose. Reduce the Rubik dose in patients with severe renal impairment. Avoid use of Rubik in patients with severe renal impairment. All right, and there is one slide in the appendix portion, and this is the individual components of the total symptom score. And the reason why this is part of the presentation is to emphasize that fedratinib has benefits that extend beyond spleen volume reduction. So when you look at the components of the total symptom scores, abdominal discomfort, well, that's probably because it decreases spleen size. Pain under left ribs, probably because it decreases spleen size. Early satiety, probably because it decreases spleen size. But night sweats, itching, and bone or muscle pain are likely independent of the spleen volume reduction. So just emphasizing the point that spleen volume reduction is not the sole benefit of this medication. And so with that, I'll end the presentation. And we have the Q&A box open, and I'd be happy to take any questions that people have. Thank you for your attention. I haven't seen any questions come through unless they're being submitted in some other way. All right, there weren't any questions that came through. I want to thank everyone for their attention and appreciate, okay, here we go. We've got one that just came through. Thank you. So why should I choose fedratinib compared to ruxolitinib? There's no data comparing ruxolitinib to fedratinib as upfront therapy. So the fedratinib study, JAKARTA 1, was on treatment naive. JAKARTA 2 were on patients who failed ruxolitinib. So the question of whether you should give fedratinib upfront versus ruxolitinib upfront is not answered. So we don't know the answer to that question. But we do know that fedratinib is effective in patients who who fail ruxolitinib. So, you might consider that in how you order these medications. There's no evidence that ruxolitinib is beneficial in patients who fail fedratinib. So, if you think about it from that perspective, and you look at how the NCCN guidelines are worded, one might consider ruxolitinib as a first choice and fedratinib as a second choice. But I'll just emphasize again that there's no randomized comparison of fedratinib versus ruxolitinib. So the most appropriate upfront therapy we do not know, but we do know based on JAKARTA 2, which was part of this presentation, that there is evidence to suggest that fedratinib can be effective in patients who have previously been treated and came off ruxolitinib. And then we have another question here. Is there guidance on how to transition from Jakafi to Rubik? Not explicitly, but there are guidelines stating about how the Jakafi should be discontinued, and that is that it shouldn't just be discontinued, that it should be tapered. What I do is I generally taper patients on ruxolitinib over a 2-week period of time, and then after they complete that taper, I start them on 400 milligrams of fedratinib. If they need to, you can give them steroid therapy to help with the taper of the ruxolitinib. It does happen that sometimes once you're tapering the ruxolitinib, it becomes clear that the patients were actually clinically benefiting and that they hadn't truly failed ruxolitinib. And if that's the case, then you can just put them on the previous dose and potentially continue the ruxolitinib. All right, any other questions? I don't see any other questions coming through. So again, I want to thank everyone for their attention and for the questions asked after the presentation, and I look forward to discussing myelofibrosis in the future with everyone. Thank you very much. Have a good day, or good evening, I should say.